Uh, yes,
So welcome everyone, and we have 3 cases from Hanoi to discuss, and maybe then after we'll discuss some other cases too. So
yes,
Dr. Han, do you want to show your case, or I have the
yes.
digital?
Yeah, thank you so much. Yes, it's my pleasure.
Okay.
Yes, yes,
Let me share the digital slide that you sent me.
yes.
Chị Hân, ông bạn ông
And let's see. Here it is.
Yes, that
So
is.
tell us about this case, Dr. Han.
This is a female, 33 years old, and the tumor is on the soft. This is the left thigh. And it has a history of 30 years of slow progression, and at this time, the surface is ulcerated and hemorrhage. So the patient came to my hospital, and in the cytology slides, I found quite numerous spindle cells with irregular patterns and vesicular nuclei, and I thought could it be a low-grade spindle cell sarcoma, and after that the clinician operated this tumor, and the tumor measured 4 centimeters in rigid dimension, and it has a yellowish cut surface and sharp, a little bit sharp.
So this is a nice example of what we call epithelial or pseudoepithelial hyperplasia related
Yes,
to these tumors. As you see over here, the normal epidermis, and
yes,
then here it
yeah,
becomes hyperplastic.
yeah,
But there's still a little bit of a grun zone between the tumor and the skin surface until you get the ulceration.
yes,
As you indicated, the tumor has a quite spindly pattern,
yes,
and has some areas of intervening collagen associated with it, as you see here.
yes,
And also, I thought it was quite interesting as we go down a little deeper. We'll take a minute for it to adjust here. We can see the pattern of spread into the fat.
yes,
And this is very typical of dermatofibrosarcoma protuberans, much more so than just dermatofibroma or fibrous histiocytoma. So this pattern of engulfing and interlacing between the fat is
yes,
quite typical.
yeah,
Now, we also have down here areas where I think you might have wondered about all of this collagen tissue down here that looks almost like fascial type collagen, or maybe some atypical rhabdoid cells or things like that. These tumors sometimes will have accompanying histiocytes, clear cells, sort of like these foamy cells here
yes,
that you see here.
yes,
And that can happen in either dermatofibroma or in dermatofibrosarcoma protuberans.
yes,
Um, The immunohistochemistry that my colleague suggested was CD34. And then
Yes.
you want to rule out things like melanocytic tumors, the SOX10,
Yeah.
and so forth. I'll share with you her comments here. So pankeratin to rule out sarcomatoid carcinoma,
Yes.
and maybe some vascular marker like a 13A or ERG,
Yes.
or something like CD31 could be
Yeah.
useful to exclude a vascular tumor as well.
Yeah. Yes.
And then
Yes.
she notes here that patchy CD34 loss could be suggestive that it's developing a more serious sarcomatous transformation, a higher grade sarcoma
Yeah.
out of that. But I think
Yes,
she's
thank
still
you.
young enough. This is unlikely to have transformed.
Yeah. Yeah. Thank you. Thank you, Professor.
So very good case and a nice example of the growth pattern, the epithelial hyperplasia, and so forth.
Yes.
So,
Thank you.
Dr. Lin, do you want to share your cases?
Yes.
Yes, okay. I want to say the breast tumor.
Do you want to share from your microscope, or shall I share the photos you sent to me?
I will send from my microscope.
Okay, yeah, do that.
Yeah. You can see clearly.
Very good, yes.
Yes.
This is breast biopsy. Yeah. The tumor cell quite uniform and polygon, not yes. The major pattern is solid of the tumor cell. And I can see the tumor very bland, not malignant, with nuclear, not typical the nuclear. And some area I can see a widen of vessel in the tumor. And not I'm not some area lúc này some in the solid of tumor with vessel and some not some lymphocyte. Tumor very with the cytoblasm very very clear.
Yeah.
And very wide, and just nuclear is not a typical. Yeah. You can do you want to see the tumor of this patient? I see the tumor which cell very like the breast cell tumor.
So when I looked at this case, I was struck, as you said, by very uniform, quite bland cells, a lot of clear cytoplasm, and solid nested growth, with maybe just like right there, one or two cystic cracks or cystic spaces in the tumor. And my differential was, I mean, I was thinking first of a myoepithelial tumor because of the clear cytoplasm and the bland nuclei. But sometimes lobular carcinoma can have a very low-grade nuclear appearance, and can be more solid in a sort of ductal type pattern when it expands the terminal ducts. So a lobular neoplasm would have been a consideration. And I think much less likely, some sort of a ductal hyperplasia or something like that, that usually has more open spaces and so forth. So you did some immunohistochemistries, which showed that these cells were uniformly positive with P63, which is a very good myoepithelial marker. They were only kind of patchy positive with CK56, but that's a less specific myoepithelial marker.
But on the modern cell tumor positive, strong positive with B63 on the modern cell tumor. But on myoepithelioma P63 positive with the tumor outside the gland, I can see the pathology outline, this pattern. But in this tumor, I see almost tumor cells are positive, strong positive with the P63 are different on pathology with myoepithelioma. Do you think about that?
Myoepithelioma?
No.
Yes, I think that is the right diagnosis. Now, usually we think of myoepithelioma as having an adeno component or a glandular component, so it's biphasic with some glands and some myoepithelial cells. But we know in the salivary glands as well that there are tumors that are pure myoepithelial tumors. And there is a myoepithelial carcinoma, but I don't think this has the atypia or the invasive pattern that we would think of with myoepithelial carcinoma. So I think what this is maybe it's an adenomyoepithelioma with very rare adeno components, or it's a pure benign myoepithelioma. I think in our institution, a proliferation like this would still be given to the surgeons to excise completely, but not be too worried about its recurrence if they have good margins. I have a couple other examples of adenomyoepitheliomas to show the spectrum of disease that we can see with that. If you want to let me show a couple of those slides.
Yes, thank you.
Yeah, so let me switch to show you these slides that I have on this topic. And so I pulled several case examples from our files that show myoepithelioma, and here's one. As you can see, it's quite well circumscribed, and this one has a fair amount of epithelial component to it. You can see a few glandular elements as well as these intervening clear cells here. So this one has a mixture of glands and myoepithelial cells, but the cytology on the clear cells is still very, very benign or very low grade appearing. You can see these nuclei. Let's look at this other lesion, which has just a very small one. This is one where I believe there is an element of malignant transformation. So here is the adenomyoepithelioma, where very clear cells, and this is arranged in a more infiltrative pattern. So this could be seen either as potentially involving sclerosing adenosis or potentially being an infiltrating neoplasm. And then over here, we have, I think here you can see this sort of sclerosing adenosis pattern with very prominent myoepithelial cells. And then here we have a more aggressive looking area with a few more nucleoli. So I think this is more of a myoepithelioma with malignant transformation that has begun to occur in this location here. And then one more example here. That we can look at here, which again shows this pattern of some residual glands. And again, I think this is because it has begun in an area of adenosis, pre-existing breast lesion that has now developed very prominent myoepithelial areas. And I think this is closer to what you had, except yours has just eliminated all of these benign pre-existing glands. So you have a more solid and nested pattern, more like these areas in your case with the clear myoepithelial cells and very little of these residual glandular elements. Does that make some sense?
But for Professor, in my case, I don't see residual gland in this tumor.
Exactly. You have no residual glands, just pure myoepithelial cells. So I think you could call it a pure myoepithelioma, without any adeno component that you've been able to identify. But if they excise it, I wouldn't be surprised if you find some small residual glands associated with the myoepithelial lesion. If you have a bigger sample of the lesion.
Yes, I will see. How do you think about the history, medical history? The patient was diagnosed thymic tumor in 2017.
2017. Okay.
Yes.
And now they have the tumor in the liver.
No. This patient has
The next patient. The next patient.
No. This patient. Next patient.
Oh, this patient.
This
The breast
patient.
tumor.
Do you think about the medical history with the thymic tumor in 2017? In 2017.
I think it would be very unusual for a thymic tumor to wait for 6 or 7 years before that reappeared in the breast. I don't think that would be very likely.
But
Plus,
I think,
the thymic tumor shouldn't mark with well, I suppose it could mark with P63, but it would be more positive with other markers. So I don't think it's related to the thymus.
yeah. Okay.
Do you want to go on to the liver tumor?
Yes. Liver tumor with patient, female patient, with 65 years old, and a patient has diagnosed liver SCC for many years before without liver biopsy. And she has undergone some ablation therapy with TACI. And now she came hospital with stomach pain, and she has cut liver tumor with with the solid button. Some area cystic button on the tumor, in the tumor. In the solid button, you can see a lot of thin vessel, and some skin cell proliferation around the thin vessel.
Are you sharing your screen? Can you show us?
Yes.
Linh chia sẻ màn hình đi.
I'm sorry. Yeah, yes, you can see a lot of thin vessel with small cell proliferation around the vessel. I think this is a hemangioma, but I wonder about the spindle cell around the vessel. Maybe the muscle cell are perivascular. Do you think about that?
Yeah, so this is a very unusual liver tumor. Not very common to see this pattern. Sometimes we call these kind of vessels hemangiopericytoma-like. They have very thin endothelial-like surfaces, and then immediately merge into the spindle cell proliferation. Usually that finding is seen with solitary fibrous tumor, but I believe this tumor was negative for CD34, wasn't it?
Yes.
And these vessels didn't stain with ERG?
I will stay with CD34.
CD31, okay.
34, that
CD34.
The spindle cell is negative, positive with CD34.
Yeah.
And a lot
So,
of, yes.
so the marker STAT6 would be very good to exclude solitary fibrous tumor. CD34 would usually be positive in both the endothelium and the tumor cells of solitary fibrous tumor can be. It doesn't look like a GI stromal tumor. The pattern is quite unusual for that, and I think your marker was negative with CD117, correct?
Yes. Yes, in CD 117 in my department now now that doesn't that now. Yeah.
Okay, okay.
And,
And didn't stain with any with Desmond or with smooth muscle actin.
yes, SMA, I was paid. SMA,
Uh-huh.
SMA, that's mean is done out. So I was paid with the SMA, SMA.
Yeah.
That's tumor spindle cell my positive with SMA.
So if we had the more specific marker STAT6, I think it would still be worth doing the STAT6 because CD34 is not a reliable exclusion for solitary fibrous tumor. But this is very odd pattern. It doesn't have dense collagen, and it's not highly cellular. The other possibility here, I think, is a perivascular endothelial cell tumor, or a PCOMA, which can have some myogenic markers like SMA, but may also express melanocytic markers like HMB45 or melon A. And so I think that would be be worth excluding as well in this situation.
I will send this tumor. You have some guess.
Yeah.
Yes.
But beyond that, I don't think I've seen a tumor quite like this in the liver. We did a few years ago describe the solitary fibrous tumors that we had in the liver, and they were more typical of solitary fibrous tumor elsewhere. If it were a true vascular neoplasm, I would expect the stromal cells to stain more strongly with CD31 or CD34. So I don't think that this is an angiosarcoma or anything like that. Could it be an angiomatoid, leiomyoma or something? I suppose that's a possibility. A Desmond tumor, a Desmond stain should also be done to exclude smooth muscle differentiation there. But usually the SMA would be more strongly positive again with that. So I don't have a great answer for this, but I think you've done a good job in evaluating it. Does anyone else on the call have an opinion or a question or a suggestion?
Yes, I understand. I see. I got it. Thank you,
Yeah.
Professor.
Professor Hassel, so I found it in some cases the cholangio adenoma, adenoma has have appearance like the fibrous like the STX.
Yeah.
So I remember in your lecture you
Yeah.
showed one case that the adenoma like this. So can you distinguish it to this tumor?
Well, that's a good question. So there are some unusual variants of cholangio lesions,
Yes.
like solid pseudopapillary lesions or cholangioblastoma. Sometimes can have odd immunohistochemistries. And I think one of those is positive with inhibin as well. So
Yes.
if we don't get anything with the markers for PCOMA, we could go on and do some cytokeratins and inhibin, potentially maybe a beta-catenin to see
Yeah.
if it was one of those more unusual bile duct related lesions.
Yes.
I was very encouraged though that the Ki67 is virtually zero. There's no uptake with Ki67. So this is probably not going to be an aggressive tumor in that regard. So I don't think it's a carcinoma. And
Yes.
even if it's a PCOMA or something, it's not going to behave aggressively.
Yeah.
Well, those are wonderful cases, and I think that sharing them this way helps me to learn and think, and I hope helps you as well. I've been studying some soft tissue tumors, preparing a lecture on fatty tumors,
Yes.
and I thought I might share some of those cases with you. So if we've got a minute or two more, let me share some unusual fatty tumors.
Thank you.
This is a series of 3 cases with the same name, the name being pleomorphic lipoma. As you can see, that sometimes they occur in the subcutis, and the terminology here is very important because this term pleomorphic lipoma implies a particular behavior that is different from another sort of similar term, the atypical lipomatous tumor that can occur in the subcutis. In this situation, the pleomorphic lipoma is more likely to have a few lipoblasts like this, and these polymorphous pleomorphic cells, whereas the atypical lipoma or the atypical lipomatous tumor, well-differentiated liposarcoma, has relatively few of these cells, and very, very rarely, if ever, will you find a lipoblast like this cell here. So in the atypical lipomatous tumor or well-differentiated liposarcoma, lipoblasts are very uncommon or non-existent. But both of these tumors can have some atypical cells, as you can see here. Now, the polymorphous or pleomorphic lipoma generally has a very benign behavior, even though it looks a bit worrisome. as you can see here, you would see this and be quite concerned about these very bizarre cells. But this is more akin to the leiomyoma with bizarre nuclei sort of case that has a benign behavior. Let's look at another example, which shows us another feature which can be seen in this, which is sort of a more myxoid appearance. And here you see the scattered fatty cells, and then this intervening very loose myxoid and fibrous collagenous tissue. But again, notice that we have, some atypical cells, and they sort of have a lipoblastic appearance, like that one does. We might have to search for them a little bit more in this one. But I think you can see here's some with a sort of eccentric nucleus, or here's a couple of lipid droplets indenting the nucleus, creating that lipoblastic appearance. So this is another piece in the spectrum of pleomorphic lipoma, where you get more myxoid tissue, rare lipoblast, and some associated collagenous tissue, along with a degree of cytologic atypia in this lesion. Going the next step, we'll see that these tumors can also have a lot of collagen, of collagenous tissue. So here's one which is much more pinkish, still a little bit of blue here, and these islands of residual fatty tissue. So here we see the pleomorphic or the bizarre cells. Again, the collagenous background, a little bit of mucinous or myxoid change. And then these multiple lipid droplet cells, and I think we'll be able to find a few lipoblasts if we look a little further. You don't have to find lipoblasts in this tumor to call it a pleomorphic lipoma, but you certainly, here's one here. So there you see that one right there. That's a nice lipoblast with multiple lipid droplets indenting the nucleus in that same cell. So those are several examples of the pleomorphic lipoma, which is quite different from the well-differentiated liposarcoma or atypical lipomatous tumor. Now, I think I have a few examples of that just to compare so that you can see that how those two lesions are similar, but also how they are different. So here are several cases of atypical lipomatous tumor or well-differentiated liposarcoma. This lesion, obviously, most common in the thigh and in the retroperitoneum. And of course, in the retroperitoneum, it is prone to develop into dedifferentiated liposarcoma, which is actually not a fat-generating tumor. So here we see the enhanced fibrous or collagenous tissue, enhanced septi of these in between the lobules. And what we would expect to see here are occasional atypical cells in this more collagenous tissue. Now notice we don't have the high degree of pleomorphism that we saw in the pleomorphic lipoma, but we do see some occasional slightly atypical cells in this collagenous stroma. And you might see a cell, maybe wonder, oh, could this be a lipoblast? Possibly, but decidedly very rare in this tumor. Here's another of these atypical stromal cells here, sort of a binucleate cell there in the fibrous stroma. So this tumor doesn't have very many of those atypical cells, but there's enough atypia here that you might raise that concern. The diagnostic test, however, would be overexpression of MDM2 because of the mutation and amplification of MDM2. Sometimes these tumors will also have express P16 quite strongly, and CDK4 as well, but those are not as specific for this tumor as MDM2. So here's another example. You can see some benign fat over here, and then this more cellular fatty tissue with a little bit more intervening tissue, and even a little bit of myxoid change here. So you might wonder, is this misclassified, and maybe this is a pleomorphic lipoma, because here we have a lipoblastic cell there and a little bit more of that myxoid stroma. So I'm thinking this might have been a misfiled case that fits better with with polymorphous or pleomorphic lipoma. And again, the MDM2 shouldn't be overexpressed in pleomorphic lipoma. So I don't think I like this as an example of atypical lipomatous tumor. So let's go on to the next one. I think this is more likely a pleomorphic lipoma. So here's a lesion. We can see that it invades the fat a little bit here. We've got some more fat, and we just have these very fairly bland fibrous septi over here. But notice that here there are occasional kind of enlarged cells, slightly atypical. And these well-differentiated liposarcomas can look incredibly bland at times, but will have MDM2 amplification. Let's look over here and see if we've got more examples of that. So here it's infiltrating the muscle. And of course, that's another marker that we might wonder, is this an intramuscular lipoma? That would enter the differential in this particular kind of case as well. So that's not a very good example either. I pulled these out and I haven't looked at them closely. So let's go on to this next one. So here's a better example, a higher power view of the kind of atypical cells in the fibrous tissue that you would see with well-differentiated liposarcoma. Now, this is developing more solid tissue, so you may be beginning to develop a low-grade dedifferentiation in this tumor. And well-differentiated liposarcoma can have dedifferentiation that goes either towards high-grade sarcoma or towards a very low-grade, less cellular sarcoma. And so if this were a dedifferentiated area, it would be on the low-grade sarcoma side of things. And it does have quite a few of these atypical cells, as you can see, in the fibrous tissue. These sarcomas don't make fat. So even though we call it a liposarcoma, it's not really a fat-producing tumor. It tends to produce other high-grade sarcomatous features and may have heterologous elements. So let's look here at one more case. Here you see a more prominent accentuation of these fibrous septae between the fatty areas. There is a little bit of myxoid tissue here, and well-differentiated liposarcoma can occasionally have myxoid areas. So when you see a myxoid fatty tumor in the retroperitoneum, it's not going to be a myxoid liposarcoma. It's going to be a well-differentiated liposarcoma with areas of myxoid change. So here's the atypical cells that we associate with this. And not a lot of them, as you can see, just a bit of nuclear enlargement, enough atypia to know it's not totally normal. And maybe we'll see some out here in the myxoid areas. Here you can see maybe a little bit more nuclear enlargement, hyperchromasia in that area. Okay, I've got two more good slides. This one and its immunohistochemistry. This one has much more myxoid change. This was actually a case that came to our institution. And as you can see, it has a lot of very myxoid tissue here. But it does have a very low-grade atypia in the fibrous tissue between the fatty lobules. So one of the reasons I like to show the kind of spectrum of disease that you can see is because most of the time our diagnostic errors are not due to not knowing the diagnosis or not being aware of an entity, but because we don't know enough about the spectrum of disease that may fall within a particular diagnostic category. And so being aware that well-differentiated liposarcoma can have myxoid areas helps you to include that in your differential diagnosis and to not miss that diagnosis. So here is the MDM2 stain for this case, or a similar case, I believe. Yes, I think it's this case. So here is the control tissue over here showing strong positivity, and our tumor tissue here with all of these myxoid changes. And you can see here that virtually every cell is showing amplification or staining in the nucleus with this MDM2 stain. So this is a very convincing, strong positive with MDM2 that would be confirmatory. Now you might get a similar pattern with P16 as well that may have more cytoplasmic staining as well, but this is a nice positive example of MDM2 immunohistochemistry. Now, I don't know if any of you have tried to adopt this antibody or not, but it's not perfect. And so sometimes if you have a negative or a weak stain, you still may get good reactivity with the MDM2 FISH technique using fluorescence hybridization. And I wouldn't if you think something is an MDM2 positive tumor and your immunohistochemistry is not working well, then go to the fluorescence test. So I think I'm going to stop here and let us see if there are any questions about these fatty tumors that we've talked about, or anything else that we've talked about tonight.
This a very interesting case about the lipoma. It's difficult to distinguish them.
Yeah. Fatty tumors are a little bit tricky, and that's why I wanted you to see some good examples.
Yeah.
Professor has also the key differentiation between the pleomorphic lipoma and atypical lipoma is yes, I get from your lecture that in the atypical lipoma we have a more solid but less cellular than the pleomorphic lipoma, as well as they don't have the myxoid background like the pleomorphic lipoma. Is this right, Professor?
So I have a little chart here.
Yes.
Let's see if I can pull it up here.
It's too difficult to differentiate between two because the MDM2 is doesn't work well in immunohistochemistry.
Yeah, so this is what I
Yes.
would summarize the staining being. One is location. Head and neck is more frequent for pleomorphic lipoma versus retroperitoneum, spermatic cord, and thigh.
Yes.
We saw the collagen is more coarse, it's thicker in the pleomorphic
yes.
lipoma, whereas this was more fibrillar in the well-differentiated or atypical lipomatous stroma and so
Yes.
forth. And then lipoblast, in my experience, lipoblast are very rare in well-differentiated liposarcoma or atypical lipomatous tumor. Some people have said they can be numerous, but I don't think so. And the MDM2. Now, I haven't done it, but I believe that the P16 staining pattern would also be different and be positive in well-differentiated liposarcoma and negative or patchy in pleomorphic lipoma.
Yeah. P16? Yes.
P16, yes.
Yes. Yeah.
And I think you do have that stain working well. So that those are the changes that I would look for. Location, collagen, lipoblast, and then your staining if you could do it. Good question. Well, all right. Yeah, I'll let you get to work and have a good day. It's great to talk to you, and I look forward to to TET like you do, and I wish you all một năm mới tiền vượng an khang, huh?
Thank you, Professor. We are very happy. Yes, and wish you a new year. A very happy new year.
Very good.
Yes.
All right, and we will talk after TET.
Yes, thank you, Professor Lewis.
Bye-bye.